No, let's you go. Once we go with that. No, that's what that. Yeah. Go with that. Thank you. Good afternoon, guys. Good afternoon. Jonesboro Rotary at the Jonesboro United Methodist Church. We're going to ask Reverend Andy Woodhouse to do our invitation.
Yeah, just want to say thank you all for supporting our lunch today. Thank you, and thank you for your service to our community. And hey, if you're looking for a church home, love for you to check us out. 8:30, 9, or 11. I'm here every week, and there's a great group of folks here.
We have a great pastor.
So yeah, I'll lead us in a prayer. Gracious God, thank you for this day, for the countless blessings that you bestow upon us. I thank you for this group of folks, for their service to our community, and we thank you for our health and for the monies that are generated here today that will further the good work here of this side of heaven. So be with those who are less fortunate, and I ask your blessings upon this Rotarian group. In Christ's name we pray. Amen. Thank you so much.
Thank you.
And we thank Andy for being our speaker at Character Plus on Tuesday. And it's an early one because everybody knows that it's changed now to 8:10. And Andy adjusted her schedule, and she's coming to talk to the kids next Tuesday.
Not bad.
Oh, my pleasure. It'll be fun.
I helped raise it.
Good to see you.
Hey.
Thank you.
It's been an interesting week for me, and I'm not really prepared for you guys today. Laying out there, I'm sorry.
What happened, David?
But anyway,
He is honest.
I've got a.
Are you vulnerable, David, or?
You know what? I just picked up a new son-in-law over the weekend. And, sent my last check out today, so this is not quite strong enough. Anyway, I do know that on the 18th, we are going to need to help the CUOC with some carrying some food from the fairgrounds to the CUOC, and I'll have more information on that the closer we get to it. I can't think. Sorry.
Oh, give it over to me. Okay. Thank you, President David. Now he's sleeping. All right, today we've got a couple of visitors. We've got Haley Westmore. Wetmore? Mm-hmm. Okay, I'm going to get my glasses on. John McDonald and Mr. Doug Roscoe. Let's give them a big round of applause. Doug, thanks so much for coming and joining us today. Since I think it's been like maybe a year. No, you came to the club a couple of times in the last year, haven't you? But we do appreciate you coming and meeting with us today. Thank you so much. If you need a application or whatever, see us. We can fix you right up with that. You know that. Okay, hey, we got a online makeup. Mr. John Ramsperger. Yay, way to go, John. Way to keep up that attendance. Super. Anybody else got any makeups or anything like that? No?
I made one up on the cruise ship coming down from Alaska.
Tell us about that.
Okay.
I actually had a combined meeting with Kiwanis Alliance.
That doesn't count.
Well, okay. All right. As a makeup, you might have to do a program on that, so keep it in mind. We might need you in a week or two. Does anany else have any announcements to come before the club at this time? Larry, yeah.
I just wanted to let you know, we did confirm with Carolina Trace that we'll have our recruiting luncheon out there October 27th, so we won't be meeting at the Flame. We'll be at Carolina Trace. And what they're going to do for us is they're going to put an article in Trace Talks, which comes out in early October, and they're also going to do a Facebook notification. And what we're hoping to do is to invite former Rotarians, and there's quite a few of them at Trace, plus other people who are interested in community service and international service to come and join us. So we expect that we'll have about 25 guests, maybe more, because there's an RSVP that they'll have to do for us. And John Farrell will be joining our club as another corporate member, and he'll have two other folks from Carolina Trace who will be part of the corporation. So I think that's really, really encouraging for us. And who wrote the bulletin for last week? Was that Robert? I mean, Robert, you gave us such a nice emphasis on the award that we won for zone something, and it had to do with something else, and it didn't even get bold. Everything else got bold. So I suppose I owe $1 for that.
It was a great story. I liked it.
Yeah.
I enjoyed it.
Let's give Robert a big hand for all the great writing he did.
Should have been a journalist.
He is.
All right. Larry started us out with brags. Howard, you got something you're proud of today that you want to share with us?
I've got $5 for you. Woo! I don't brag very often.
That's a big brag.
My non-hunting friends won't be impressed, but 2 weeks ago, on Wednesday, I was in the subarctic, about 600-700 miles north of Montreal and Quebec, up in Nunavut, Inuit country, otherwise known as Eskimos. And on Wednesday in the morning, I dropped a bull caribou. At noon, 4 hours later, with about a 2-mile foot chase, I got a 300-pound black bear. And that evening,
Was he
chasing
chasing you?
we squared off a little bit. Then at 5 o'clock the same day, I threw I had a little $20 pocket fish link. You're limited to 65 pounds of gear, which is really too lightweight, but we were in a boat trying to catch lake trout for the first time, and I pulled out a 26-inch, 6-pound lake trout. So I got 3 trophies in one day. And then 2 days later, the guide said he'd loan me his little single-shot 20 gauge. I went up and hunted ptarmigan, which are subarctic grouse, and I managed to get 2 of those. So I came back with 4 trophies to have mounted.
Wow.
So
That is worth it. Okay, anybody else got any? Yes.
Yeah, well, we just came back from Cape Cod, and one of the highlights was a whale watching trip. We ended up seeing about 40 whales. It was just incredible. And although we didn't shoot any, it was a
Just
great
spear a
trip.
few.
Take Howard with you next time.
Thank you, Andy. Appreciate that. Anybody else got anything they're proud of they want to brag on today?
And I'll have to.
Yeah.
I'll have to brag on the wedding. Nobody got shot. So that was pretty good for the weekend. So the weather cooperated. You know, it rained like crazy on Friday, Saturday. We got married down in Wilmington, and Saturday the weather broke, and she was a beautiful bride, and it was just a good weekend. So.
Fantastic.
It was good.
Let's give him a big round of applause. Anybody else?
Yeah, did everybody sign this for Stacy? I'm going to go up and do a program for her on Wednesday. And instead of getting her a regular card, since she was so involved in designing this brochure for us, we thought this is the thing to do, to sign it and give it to her. So, Doug, I don't think, and Kemi, can you guys sign it, please? Anybody else?
What a brag.
Terry, yeah.
Like I said, man, he was so good.
Yeah, wait, he's already got the camera.
No, I already got the camera preset. United Way breakfast at the Lincoln Hospital. So I got the opportunity to go and video the breakfast. So I told John Maxwell that he needed to go to YouTube because the day that he came over to the Rotary Club and spoke, I put on there, John, would you please join the Rotary Club? Join the Rotary Club. So Larry, I would like for you to go back and help me find the date so I can send John the link.
I can do that for you.
Then once we get John to join, we're gonna try to get all these little nurses and the doctors and everybody else to join. So we might have a whole medical staff. You never have. I used to be a recruiter for 10 years in the Marine Corps, so I'm all about recruiting. So.
You can recruit them in the Marine Corps. You can recruit them anywhere.
Yeah, someone come back to haunt you though. All right, anyway, that's my little 15 seconds.
Thank you for sharing that. Anybody else got anything to come before the club at this time?
I have a quick announcement.
Tammy.
Yeah, since Chris isn't here, I figured I'd remind you guys that.
Good idea.
Yeah, we have the Sounds on Steel Music Festival on Saturday, and so it's from 12 to 9. We have 10 different bands playing. There's going to be great music, great beer. There's 4 different breweries coming, food trucks, so it'll be a good time. It's going to be all day on Saturday, right off Carthage Street, across from the Temple Theater. So I'll pass these around in case anybody wants to get.
Tammy, thanks so much for sharing that. Are you helping out with the?
I am,
All
yeah.
right.
So I'll be there all day helping Chris out. So it'll be a good time.
Fantastic.
Yeah.
I saw him this morning. He said if he gets through Tuesday, he'll be all right. So
Yeah,
he's got
right.
quite a few
It'll be a
things-
busy weekend, but it'll be a good time.
things on his plate.
You
and
work
he's
at
got
the theater
that,
now?
dinner
Just helping him out.
Monday at the Steel Pig. Okay. Anybody else got anything come before the club this time? Back to you, President.
Thank you. I think what we're gonna start doing is, Terry is everywhere. So instead of these "Where's Waldo," we're gonna start a thing. Somebody come up with that. Where's Terry? So we'll just follow him.
Yes, Terry.
Anyway, he does a great job at all these events, and we're proud he's a member of the club. So, Doug.
Okay. Thank you, President David. I want to introduce Haley Wetmore. She is originally from Broome and went to Appalachian State, so she's a kind of a North Carolina local lady, but she's lived all over the Southeast, I think. She works as a stroke specialist with Medtronic Neurovascular for Eastern North Carolina. And she's going to be talking about a really interesting, fairly new development. It's really great because we live in a good part of the country to take advantage of the community. So, Haley?
Yeah, absolutely. Thank you so much for the introduction. It sounds like I need to be hanging out with some of you guys, the whale watching and the shooting guns and all that
Do you
stuff.
need an application?
I know. It sounds like it. I live a little bit too far away, but thank you guys so much for having me today. Like Doug said, I am the stroke specialist at Eastern North Carolina. A lot of my job, I get to do fun stuff like this. So I have community outreach, I do EMS education, and then I also get to go in the hospitals and work with the doctors. So a lot of the times I'm in scrubs. So today I'm going to start out. I'm hoping you guys can hear this. If you can't, then we'll just scratch it and I'll move on to my presentation because we could not find an audio cord. So we'll start out with this and move on from there.
Driving to work, had a bruise on my neck that I felt. I didn't see it, and I rubbed it. And after I rubbed it, about 5 seconds later, I felt like I was going to pass out while I was talking to myself. And I was like, what's going on? As I was driving, I couldn't see out of my left eye. I was driving along Center Divide a couple times, and it was like a dream. Like you're having this dream, like something was going on, but you can't stop it. I ended up running off the road. Finally, somebody had called 911 that I was a drunk driver.
I remember the call. It came in as a single vehicle traffic accident. I remember as we walked up, the vehicle was still on. He was actively trying to put it into gear.
He was talking to me on my left window, and I couldn't see him or hear him. I heard him from my right side, and then I remember saying, "Where are you?" when he had to yell at me. And I looked over like, "Oh, hey."
There's kind of a look of confusion on his face. I asked him if he had been drinking or taking any drugs. He said no, and I asked him to smile to see if he had any facial droop.
I smiled for him, and I was like, "I think you're having a stroke, buddy. We're gonna get you some help."
Immediately saw that he had facial droop. Go back to my part of the stroke code.
Part of our stroke protocol, we have EMS pre-notification when there's a stroke code en route. They actually send a page saying we're on the way, even MICN call, stroke code coming, ETA 5 minutes. So we knew Sept was on the way.
They took me to the hospital. I got there, and it's a sea of doctors, and they got the call that I was coming in.
So I had gone to work a little early to get a couple things done, and the call comes in, and it's the hospital.
at UCSD, and they said, "Your husband's okay and had a stroke." And I'm thinking, that's not okay. I'll be there in 10 minutes. And I knew my only job was just to drive safe.
It was actually a really chaotic day in our emergency rooms. He was the third stroke code within a few minutes. So when he hit the door, it was actually quite obvious to us that he was suffering a stroke. That he was paralyzed on that side of his body. We transported him to do a CT and a CT angiogram. We were first able to rule out that there was no blood in the brain, but there was actually a very large clot sitting on the right side of his brain. We had already contacted Dr. Gillespie, our interventional neurosurgeon, when we saw the clot on CT.
The stroke neurologist at UCSD reached out to me by phone and said we had a young man who's coming in within the therapeutic window with a confirmed M1 occlusion and that they thought would benefit from a thrombectomy.
I get into the emergency room and I tell him that I'm there to see Sept and he had had a stroke. He comes back and says, "Okay, they're ready for you, and just so you know, there's 8 doctors." They had given us 3 choices. The last one was to do an embolectomy, go up through his brain, and pull the clot out. We thought, well, we're going to go with that one because that just seems like the quickest way out of what we're in. So I go into the waiting room, and Dr. Gillespie came out to me and he said, "You have every right to expect the best."
I can tell you 3 or 5 years ago, that's a very different, difficult conversation. So I was very, very optimistic in the conversation with her that we were going to be able to get her and her husband a good result, and we move forward.
I remember having this urge to sit up, like so bad, and I asked, "Can I sit up?" And I remember him yelling at me, "You can't sit up, I'm in your brain right now." And shortly after that, I had this headache that came, and I went, "Ow," and he goes, "Yeah, you're gonna feel that." When he was done with the procedure, he said, "Okay, I'm out of your brain, you can relax, you did a really good job." And immediately I started trying to move my hand, and to me, within 5 minutes, I was moving my hand. And I was trying to move my foot, and I was like, "I can move my hand, I can move my foot," and I heard, "We got movement." But when they yelled, and it just getting overwhelmed, I started crying.
Usually they're not quite as spirited and interactive. And the payoff of that, though, is when we were able on a single pass to actually open that artery for him, we saw the immediate the restoration of movement on the left side of the body. And I can tell you it's a rare and very special privilege to have that experience and be able to share that with the patient, obviously in real time.
He comes back in 20 minutes. But here he is, he's looking at me, he's light in his eyes, there's magic in the air, and he says he's moving his entire left side.
And it was pretty remarkable because right after removing the clot, we actually saw Stefan moving his hand, and he had immediate recovery of his symptoms, and only continued to improve after that point until the point that he was actually back to normal.
When they wheeled me out, you could hear the doctors and the nurses that saw me go into the operating room, and you could hear this. "There's no way." That's what I heard. "No way, that's him. There's no way that's him. How's that him?" And that's what I was hearing. I was like, "Oh, I must move back."
I think it was 5 minutes they're pulling him back out of that room. Like my husband's literally waiting with his left hand.
The fact that he's a young father of 2 made it all the more exceptional. So I think it was one of the reasons why both myself and our entire team kind of come to work every day is to be able to make a difference in kids like that.
I was really happy to hear recently that he's actually back to his normal activities and he's able to work 100% of his job blow drying without any difficulties, which was actually a problem at the very beginning. So he's really back to his normal life, which I'm happy to hear about.
This procedure, this hospital came in on a Wednesday and they gave us Tuesday. And very rarely in your life do you get a rewind, and this gave us what we came in with.
I'm so thankful for this procedure that UCSD was able to offer me, and just thankful that I was able to have the chance so I could spend my life with my family, my son, daughter, wife, parents, and everybody. Thank you very much.
I'm so glad to hear that Stefan is doing so well that he's serving again.
I'd like to thank the American Stroke Association and Medtronic for their commitment to ending stroke.
So pretty crazy, huh? So that's, I get to do that sort of thing and help save lives in the education that I do. So it's pretty awesome. So I'm going to kind of dive into a little bit about stroke and specifically acute ischemic stroke, which is what Stefan had. And please, this is very informal, so please feel free to raise your hand, interrupt me, ask questions. So we're going to start just a little bit with some statistics. So I'm not going to read this slide to you guys. You can kind of read it on your own. Some of the ones that stick out the most: every 6 seconds someone dies of a stroke. 1 in 6 people will have a stroke at some time in their life. One other thing on here, if you look at the bottom one, it's responsible for more deaths annually than those attributed to AIDS, tuberculosis, and malaria combined. Not only that, but a statistic I actually just heard is it actually kills more women than breast cancer. So if you think about all the education that's around breast cancer today, and everybody knows about breast cancer, and that's wonderful, but this just goes to show that there needs to be a lot more education when it comes to stroke. Here are some other ones. It's the number 5 cause of death. It used to be the number 4. So the number 5, we're moving in the right direction, but there's still a lot of work left to be done. About 800,000 Americans suffer each year of a stroke, and then actually 80% of those can be prevented. Okay, so we're going to get into that now. So these are the 3 different kinds of strokes, okay? The one we're talking about today is the ischemic stroke on the far left, and that is when a blood clot goes into the brain. Okay, so there's a blood clot in a vessel in your brain. It's 87% of the strokes. Then there's intracerebral hemorrhage, which is bleeding into the brain, and subarachnoid hemorrhage, which is bleeding around the brain. And these are the 2 treatment options that are available today for acute ischemic stroke. So there's IVTPA, which I always like to just call it Drano. For those of you guys, think about Drano going into your pipes and breaking up all that mess, okay? So IVTPA is a blood clotting busting drug, okay? So they put it in and they try to get the blood clot to move. These patients that get IVTPA, they have to be within 0 to 4.5 hours. This side says 0 to 3, it's a little outdated, but the American Heart Association changed that to 4.5 hours. So a patient has to be to the hospital in time to get this, okay? If they're outside that window, they can't get IVTPA. Not only that, but if they're on a certain drug that might be a blood thinner or other things that might have happened, they might have a history of something that prevents them from getting IVTPA, okay? So that's IVTPA. Then we have mechanical thrombectomy, which is stent-based retrieval of a clot. So this is able for patients to have up to 8 hours out of a stroke. So it's a little bit further time than the IVTPA, right? What's also great about it is if a patient either fails IVTPA or can't get IVTPA, they still might be a candidate for mechanical thrombectomy. But again, it's in that 8-hour window. Okay, any questions from that?
What happens after the 8-hour window?
So, for the most part, FDA approves it, only out to 8 hours. I have seen physicians, if they do a CT scan, which is how they base whether or not to do this procedure or not. If they see that there's salvageable tissue, which we're about to go through, they might go in. But after a certain time frame, you're kind of out of luck. So, yeah.
And
so that's why. Go ahead.
Can you use both treatments? Or
Yes, you can. Yeah. So ideally, that's what you would want to use. You would want to use IVTPA in conjunction with mechanical thrombectomy. But if for some reason, again, if that patient's outside that time window for IVTPA or they're contraindicated because of a drug they're on or whatever, they might just have mechanical thrombectomy.
But wouldn't IVTPA be a blood thinner? So essentially going inside, how would you keep them from bleeding out?
John, is that, that's a good question. They're on a lot of different, when they're doing this procedure, they're under surveillance at all times. So they're very, very careful about what they do. They're measuring their body weight before they're giving them IVTPA, so they know how much to give them, so they're not going to cause any issues. Can you add anything to that?
Part of it is a great question, because part of the screening process to be considered eligible for IVTPA, they're going to take a history from you. They're going to ask you, well, have you had surgery in the past 6 months? Have you had any dental procedures? Have you fallen down and bruised yourself? Because if any of those factors are present, then you can't give this agent just because of that fact, because it will cause you to bleed. But in an otherwise healthy, intact person, this will attack the clot. It has a relatively short half-life, so it doesn't hang around the body a long time, but it will attack the clot and dissolve it, so restoring blood flow to the artery.
And I'll hope, that will work. Any other questions?
He's got a question.
Sure.
Did the guy in the video fell? I mean, he's obviously young. Sounds like he got there in plenty of time. Did he fell for IV?
I'm not sure. I don't know the history of that video. That was in California, so I don't know. I'm assuming that hopefully he did. I don't. but I don't want to tell you the wrong thing. Anything else before I move on? Sure.
When you break up a big clot, you presumably make small clots that move down the line.
That is true. So there's risk of, we call it distal emboli or distal blood clots from breaking apart, and that's why mechanical thrombectomy or the stent retriever is important for clot removal, which it's recommended.
Almost sounds like it needs to be first.
Like the clot retrieval, which
Yeah.
sometimes it is, and there's studies going on that might be doing that at some point. So, anything else? Yes.
I want to share with y'all at 5 o'clock yesterday morning, my father-in-law had a stroke.
Oh my gosh.
So that's how close things hit home. Immediately he got life flighted to Cleveland Clinic, and he's doing pretty good right now, but he'll be there throughout probably the weekend for observation. But I think and this isn't his first battle with this.
Wow.
He had a heart attack when he was 37, and when he was like, I want to say 55, he had a stroke, and that really slowed him down quite a bit, but he was able to relearn everything and come along pretty good.
Well, I'm so sorry. I'll be thinking about him.
But that's how, I'm sitting there and I'm looking at all your stuff and I'm going, wow.
Yeah.
My father-in-law, yesterday morning, 5 o'clock.
Yeah. And it can happen to any of us. I mean, it can happen to young kids and children even. So it's.
I was talking to my friend, and we're like, you don't wake up in the morning and say, I think I'm not too busy today. I might have a stroke today.
Yeah. No, you don't. And it can hit anybody. And you're right. I bet all of us have somebody we know or has been affected by someone who's had a stroke. So appreciate you sharing, and I'll be thinking about your dad.
Thank you.
Anything else? Okay. So this is going to go into a little more detail. This is the ideal acute ischemic stroke or mechanical thrombectomy patient. This is what doctors are looking at. So this patient has a blood clot in their middle cerebral artery. So we all have middle cerebral arteries on either side of our head. So think about rubbing your hair through your hand through your hair. That's where your middle cerebral arteries are, okay, in that area, okay? So this patient's having a blood clot in that area. When the doctors are looking at CT scans, they're looking to see the core, which is the irreversibly damaged part of the brain. Okay, so that cannot be brought back. What I was talking about earlier with you was the penumbra. So this is the salvageable tissue of the brain. So if the core was as big as the penumbra or almost as big, the doctor would probably not go in just because it might cause more damage than treatment, betterment for the patient, because it could cause bleeding or other complications. So this is the ideal patient, okay? Just to kind of put it in perspective, so every single minute, there are almost 2 million neurons lost in the brain, okay? And it may age the brain by 3.1 weeks. So you think about someone who's been having a stroke for even just 30 minutes or an hour, the damage that can happen to someone's brain in that time. So I don't know if I've said it yet, but I always say time is brain. It's extremely important that if you notice any stroke signs or symptoms, that you get to a hospital as soon as possible and call 911. Okay, here's some clinical data. I'm going to go through this pretty quickly. This is just kind of the history of how everything came about, okay? So there were 3 failed trials back in early 2000s, and the reason that they were failed is because there was poor patient selection. So they weren't doing the CT scans that we just discussed, right? So they were kind of just picking whoever. And then they were using some of the old devices. So they were using a Mercy device and the Penumbra device. And I'm going to go into those later, but that's the reason they failed, okay? So what happened in 2015 is at Medtronic, we actually sponsored 5 clinical trials, and they were all positive. And the reason they were positive is because of these criteria, this criteria. So we had the IVTP that we talked about within that 4.5-hour window, and most of these trials had the endovascular or the stent retriever within 6 hours, okay? The NIHSS scale, which is just a scale that they use to tell the severity of a stroke. So, if the stroke is a 1, it's not a very severe stroke. If it's an 8 or higher, it's going to be a more severe stroke. And then the CT imaging that we've already discussed, the importance of that and why it's important. And then these trials were also a lot faster. So from the time the patient got to the door to the CT scanner to the doctor to do the procedure. It was just a lot faster. And because of all that, which is amazing, the American Heart Association completely changed their guidelines. Okay, so they saw these 5 positive trials and the effects. Some of the trials were actually ended early because of how well they were doing for these patients. The American Heart Association said, okay, you know what? Stent-based thrombectomy is the standard of care. So everybody that has a large vessel occlusion or an acute ischemic stroke, this is what they need to have done. This is the standard of care, okay? And that was just published last year. So June of 2015 is when all these guidelines changed. So it's still really new. And then this is just, again, the history. I wanted to talk to you guys about these devices. So we started out in 2001, I believe it was. Is that right? With the Mercy device. So the Mercy device was the first stent retriever, and it was kind of like a corkscrew. And that's how it worked, and it would pull out the blood clot. And then the Penumbra system is aspiration. So you can see here it has like a little dagger. So it kind of breaks up the blood clot and then sucks it out. And then we have the stent retrievers down here. So we have the Solitaire device and the Trevo device. And I brought the Solitaire device for you guys today. This is, I think this is one of the larger ones. And if you look, I'm going to pass it around so you guys can all touch it and feel it. You're not going to break it, so don't worry about it. You can touch it and see how soft it is, and then it actually goes completely flat. So if you run your finger through it, it will go completely flat and then go back on itself. It's almost like if you think about a roll of wrapping paper at Christmas, how it kind of springs back on itself. So the way that it works is when it goes into the vessel, it's going to unsheath and then kind of impregnate that blood clot and sit there on a couple different planes and really get that blood clot into the stent. Okay? So I'm going to pass that around for everybody. And then this is kind of the procedure. You guys saw it in the video with Stefan. Just very simple. The way that they do this is the doctor goes in through the groin, so through the femoral artery, with a guide catheter, and they would use that as a railway system. So they take that and they move it all the way through their body, through the aortic arch, and they position it in the internal carotid artery, and that again is their railway system. From there, they put a microcatheter in, and that would go further distal into the middle cerebral artery that we talked about, or into the intracranial vessels. And then from there, they deliver the Solitaire device that you guys are passing around. So they would put that in the microcatheter, pull that up right to where the blood clot is, unsheath that device, and let it entrap the blood clot. And they wait 5 minutes to make sure everything's in there, and then they pull everything out as a unit, and usually have the clot. Yep, they reel it in. And I actually brought a flow model for you back there. If any of you guys want to, after my presentation, if you have any questions, I can show you kind of how the procedure works on a little tiny flow model back there if you're interested. Sure.
You said they go in through the groin.
Yes.
For the heart, now they're going in through the wrist and the arm. For this, they still have to go through the groin.
They do. They can go through other places too. That's just their choice because it's less invasive, I guess. It's not as hard to get to. It's easier for them to get to there from the groin. So, anything else? Okay. Any question? Okay. All right. So this is. I told you guys at the beginning of my presentation that a lot of my job is education, community outreach. And a lot of what I do is EMS education. So I do a lot of outreach to them on education about ischemic stroke, identifying ischemic stroke in the field. So knowing the difference between a subarachnoid hemorrhage and a large vessel occlusion and where to take their patient, right? So that's a big part. They're our first responders, right? So they need to know what's going on. And then we have the primary stroke centers, which we have a lot of in this area, that are able to take a stroke patient and they're able to give them the IV TPA. And then if they need the mechanical thrombectomy, they'll ship them to a comprehensive stroke center. So go ahead.
Have you done the education for the local group here?
The local group, the local hospital? I have not.
I know the director real well. I'll give you a sign.
Yeah, I would love to. I've done quite a bit in this area, but not the local group. Yeah. And then the primary stroke centers, like I said, they're going to do the IV TPA, we call it drip and ship. So they give them the IV TPA, and then they're going to send them to a comprehensive stroke center. So for you guys, the comprehensive stroke centers in this area are UNC and then Duke. And Duke Raleigh also does it. So those are the ones that are going to be able to do this procedure at this time. Okay. And then this is just kind of a referral pattern. I do want to let you, this is kind of an outdated slide as well, but the comprehensive stroke centers, there are only 750-ish in the whole country. There are about 1,600 primary stroke centers and about 6,000 community hospitals. So it's growing, we're getting there, it's just going to take some time. And then this is just something I wanted to also talk to you guys about. This is something I also talk to EMS about when I'm talking to them about strokes and how to identify them. So for those of you who don't know, the left side of your brain actually controls the right side of your body, and the right side of your brain controls the left side of your body. So if you look at a person who's having, a left hemisphere stroke, they're going to have left gaze, so they're going to look towards the stroke, so they look towards the weakness, but they're going to be slow on the right side. They're going to be weak over here. The right hemisphere, again, same sort of thing. They're going to look towards the clot, and then they're going to be really weak on this side. And then a brainstem stroke obviously appears pretty differently. They're going to have that nausea, vomiting, difficulty speaking, swallowing, and that sort of thing. So those are kind of the different ways that it might appear. And then these are the hemorrhagic symptoms. So the other strokes we talked about earlier. So again, nausea and vomiting, worst headache of your life, and all of the things that are up there. And then I always like to bring these up. So these are the controllable risk factors and the non-controllable risk factors. So again, you guys can all read those. I think it's pretty self-explanatory when you look at the controllable risk factors that, if your blood pressure goes down, you're less likely to have a stroke. If you don't smoke, you're less likely to have a stroke. So those are all controllable, and then non-controllable are over here to the right.
Haley?
Yes?
Since we're in Sanford, let me try to understand again. If you had properly trained EMS, that would recognize that you're a victim of a stroke.
Right.
And I guess I'm trying to get an idea about the decisions that they might make as to where you go. Is every EMS in Lee County going to take you to CCH, or is somebody going
I would say they'd probably take you to the closest hospital, and primary stroke center preferably, because UNC is going to be too far for them right now, okay? So the biggest thing for y'all's area is call 911, and then they're going to take you to the closest facility. From there, they can identify whether or not they need to take you to UNC for this procedure.
Okay, that's going to be the responsibility of the EMS doc.
Yes. Yeah.
Who will hopefully be able to determine that you have had a stroke.
Right.
And then would Stanford, before they ship you off somewhere, would a CT be performed here?
I don't know how CCH does it. I'll be honest, I haven't had a chance to meet with them. I know some hospitals will do it, and then what they'll do is they'll send it to the comprehensive stroke center for them to review it. Sometimes they'll say we think that this is a large vessel occlusion, and then they'll take them to the comprehensive stroke center where they'll then get a CT scan to either confirm or rule it out. So yes.
I'll tell you what my belief was. It's been going on 2 years, so things have changed. And actually, the protocols have all changed in the last 2 years, so a lot has changed. But it's my belief that no one is going to leave this area without going through the hospital, and they will immediately get you a CT table. And there's actually a telemedicine program that's there, and it's been there for several years now, that a neurologist is on call, and he will advise the ER doctor what to do. And I'm sure that some of these are going to do.
Yeah, and there's a ton of telemedicine in this area. I mean, I also work with like Winston-Salem and all those hospitals over there, and all of them have telemedicine. So just rest assured that hopefully, when you go to the hospital, they'll know that you're having a stroke. They'll be able to handle it appropriately.
What masks the symptoms that would keep a doc from getting a CT scan?
We're getting ready to cover that.
Okay.
So here are some common stroke mimics. These are some things that might happen. Stroke is really hard to identify sometimes. So if you look at the cards on your table, the FAST. So the FAST, what does it stand for? It stands for face drooping,
speech, and time.
Yep, arm weakness, speech difficulty, and then that means it's time to call 911. A lot of people, unfortunately, don't know the symptoms of a stroke, right? So I've heard stories of people waking up and their arm is numb. Oh, I'm fine. I'm just going to take some Tylenol, no big deal. Still numb. 3 hours later, they don't even know that they're having a stroke. So you don't have to have all of these symptoms, just one of them. Okay, so it could be that you have the facial droop, but everything else is fine, or you have the arm weakness, but everything else is fine, or your speech is a little slurred, something's wrong. But like, it doesn't have to be everything.
So is there any, you could have these symptoms and not
And
have any
not know.
pain?
Right, exactly, and that's the thing, and that's kind of hard with my job is with EMS paramedics. I don't know if you guys know any of them in the field, but in my experience, they're very like adrenaline junkies, you know, and they like to have things that are exciting. So with a heart attack, you know you're having a heart attack, right? Because it's pain, and the patient is going to be screaming usually. With stroke, most of the time the patient is not in pain, and they're lackadaisical, and they're just kind of sitting there, but their brain is dying the entire time. So it's just as much as an emergency and should be treated just like a heart attack. We've actually tried to kind of shadow what the STEMI has done with stroke care to get it in as fast as possible. So we're working towards that. But yeah, it's you could definitely not be in a lot of pain. And there are people that are having strokes that might not even know they're having strokes, and somebody has to tell them, or they have to recognize that that happens more often than not.
But for the ER doc, let's
Yes.
assume the
ER
EMS
doc-
guy does the right thing, gets into the hospital. What helps the ER doc determine, I think
They-
it's a possible stroke, I need to make sure it's
Yeah,
CT done?
they have scales that they use. So the NIHSS scale that I was telling you about, they use a scale that kind of helps them determine that. Is there anything else that you would think that they would use?
Yeah, I mean, it's a great question because, so the ER physician is trained to go through a differential diagnosis. Okay, what could this be? And it could be 100 things. So what's she going to do? She's going to take a blood glucose. All right, is the patient's sugar level tolerable? Are they having a diabetic coma and not a stroke? Rule that out. Once she goes to
Clock's
the different,
ticking.
yeah, clock's ticking,
Exactly.
exactly right. And
That's
this is
the
all
thing.
done
I'm
in the
afraid.
span of 10 minutes, right? So once you've run through all the differential diagnoses, and you know what, I think we've got a stroke here. She's going to send that patient up to the CT scan, and the CT scan is going to be the definitive diagnosis. Absolutely, we're having a stroke. There's a big clot in the mid-cerebral artery. We need to give TPA and ship them up to Duke, or we need to give TPA and take them to our cath lab so we can pull this clot out with a mechanical thrombectomy.
And I can get the ER director, Dr. Kafan, to come. He's been the director for a long time. He's an outstanding ER doctor. And this has had a huge amount of discussion because there's a lot of strokes in the course of a year.
We're in the stroke belt, right?
Yeah,
We
this
talked
is the
about
stroke
earlier.
belt. I mean,
Yeah.
North Carolina goes right down through the middle.
Yeah, if you have your, I should have brought the slide that shows the whole country, but we are like, they make it purple, so it's like light purple, and then we're like dark purple, you know, right in the stroke belt.
Well, it seems like you should be assuming. There you go.
Where are we?
Stroke.
Why are we in the stroke belt?
Because
Okay.
it's also referred to when I do diabetic stuff is the Kentucky Fried Chicken belt.
Exactly. So that was going to be my point. So a lot of the reason we're in the stroke belt is because of poor diet. So a lot of, we're in the South, so we have that Southern food and the Southern cooking and the
Goes with
sweet
it,
tea
so
and-
obesity chart, when you look at the US
Yeah.
heat maps, if you come down here, just the obesity rate just
Yep.
rises.
Yeah, it's just poor diet, is the majority of it, so unfortunately, yeah. So we're right here in the stroke belt.
Me and Kevin are kind of sucking in a little bit.
What do we have for lunch?
I know, right? What did you guys have for lunch, Claire?
Does the CT rule out a stroke?
It can. So if they get a CT scan, correct me if I'm wrong, if they get a CT scan, sometimes they might not be able to tell just from a CT scan. So there's other scans they can do that kind of dig in deeper to really show whether or not there's a clot. There's a ton of different softwares that hospitals will use that will really help show as well. So it doesn't necessarily rule it out. So there's been times where they've done like a CT and they're like, oh, we need to do a CT angiogram or something, an MRI or something that's a little bit more in depth. So does that answer your question?
Yeah, I guess I'm still back to looking for why an ER doc wouldn't do a CT scan if we're in
Yeah.
the stroke belt.
Right. I think if they had the opportunity and they felt like there was any risk that they would.
But you know, it's a good question, but you don't want to necessarily, you don't want to be too cavalier with giving CT scans because you're exposing the patient to a pretty high dose of radiation.
Yeah.
So if you determine through your differential diagnosis that this isn't a stroke, this patient is actually having a seizure, or the blood sugar is so low, he's entering into a diabetic coma, there's no need to go to the CT. I mean, you fix the problem right there. But if you're teasing through all of this differential and you say, gosh, I think we may be having a stroke. Absolutely, then you got to get the image.
Yeah. So this is just what we went through a moment ago. And then these are just some case studies. I have one over there that was from Duke that I brought, but this is from UNC. This is actually one of my favorite stories. This patient was a 60-year-old male, and he came in with an NIHSS, if I can read it, of 18, so which is a pretty high stroke scale. He left, I believe 3 days later with a 1, so almost like no recognition that he had a stroke at all. 2 weeks later, he went on a cruise with his wife and was completely back to normal. So this is one of my favorite cases that we have in this area. This is a case actually I used to have Virginia. So this is a case that was in Virginia. This was a very fast case. This patient came in at 2:45, was his last known well, and he was back to having reperfusion at 5:01 p.m. So super fast. They got him to the hospital right away. CT, IVTPA, got him to the cath lab, pulled out the clot, and he was doing a lot better right after that as well.
So this is cool. So yeah, look at the, what do you notice about the picture? The left side of the picture is the patient when they hit the emergency room and they took them up to the CT scanner, they took this picture, and compare that to the picture on the right side. What's different?
Looks like they untangled the wires.
And the right hand branch.
Exactly. So show them where the clot was and show them where.
So the clot was right in here, okay? So they pulled it out,
Showing up.
and you can see that all of this opened up.
You see what was missing on the left side? All those arteries were not
were
transparent on the CT because the clot was blocking all that blood flow. You
Yeah.
pull the clot out.
And then if you look at this one too, so I have the little arrow pointing, but that was the blood clot there, and then they reproduced.
So they knew that right hand branch should have been there.
Exactly.
Right.
Wasn't there, therefore the clot had to be somewhere.
Exactly. So when you see there's no, they look for it there. And they're under flora, so they have these biplane rooms, and when they're doing these procedures, and I get to go back there sometimes, which is really fun. And they're under flora the entire time, so the doctor knows exactly where his catheters are, where the blood clot is. He can see, where his device is, so he's able to pull it out and position exactly where he wants it. So, and then this is another one from Duke over here. Obviously, this is the clot here, and then that was afterwards.
So how do they make it bend where they want it to bend?
It's just so so first of all
When I go fishing, I can't.
Oh, well, that's why there's all these different catheters, right? So the balloon guide catheter is the railway system, is what we call it. So that's going to get them. It's a little bit stiffer of a catheter, so it's going to get them to get up there and find that railway system.
But I've gotten up there and I've got a left branch that is straight almost, and a right branch that should be there. How do I get it to turn right?
These guys are phenomenal. I've tried to do it. I have tried.
Directed drilling?
I think it's just practice. We have this big squid model that they have us use when we're training. It's like this big model, and they have us pretend like we're doctors. And for the life of me, I don't know how they do it. And I'm sitting there and I can see exactly what I'm doing. They just have. They're great training. They're excellent doctors. We have some of the best doctors in the country right here in North Carolina. So we are very fortunate for that, at least, and especially in the Triangle area. And over here we have Duke, we have UNC. So we have the treatment options. The main point is, if you're having a stroke, there are ways that you can get better. It's not just back 3 or 4 years ago, it was like, oh, you're having a stroke. Well, good luck, Now there are things that can completely change your life. I mean, I heard a story just yesterday of a 31-year-old, she was actually 30 when she had her stroke, young mom, school teacher, that's my age. She completely collapsed, back to normal, back to working, back to her kids, completely back to normal. So these stories happen all the time. Tonight, actually, we are doing a stroke survivors dinner in Raleigh with a couple of the Duke survivors. And we're bringing in EMS paramedics to kind of close the loop and thank them for all that they've done to get these patients to the hospital in time. So it's there for you guys. If you know anybody that has a stroke, let them know. Let them know. Please tell people. That's the biggest thing, is that a lot of people don't know. I mean, did you guys know that this was even an option before you came in here today? Okay, so do me a favor and take 2 minutes and tell 2 people that you possibly, wouldn't know this information, and let them know that, first of all, the symptoms of stroke, and to call 911 as soon as they have any of those, because there are options that can bring you right back to the life that you're looking for today. So.
How long for the whole procedure to run it in,
Right.
all the different things up and
Yeah.
down, grab and get out?
So it takes it depends on the process, right? So some of these are really, really short procedures. So let's see, this one over here, he was in and out, so he had groin puncture and he had pulled the clot out within 24 minutes. So once they get in there, it can be pretty quick, depending on the anatomy of the brain. Okay, so some people might have more tortuosity, is what we like to say. It's a little harder for the doctor to get up there, or they might have some other things that are going on, so it might be harder. But for the straightforward case, I mean, it's quick. They're in and they're out. The thing that's hard is getting them in there, right? So getting them to the emergency room, CT scan, decision being made, then go to the cath lab, then everybody scrubs up, everybody gets ready. So the whole process is, what's the longest is getting them there, right?
Correct.
And then once they get in the cath lab, it's usually a pretty quick procedure. So, any other questions? Because this is the end of, man.
We use the term cath lab.
Yes.
And for us in Sanford,
Yes.
that cath lab is.
Is probably UNC.
Okay.
Yes, or Duke, whichever one is closer.
Thank you so much.
You're welcome.
That was very informative.
Thank
And
you.
Realize what a smart group we have here. These questions were just.
Yeah, you guys asked a lot. You guys asked a lot of good questions. And if you guys have time, I do have the flow model back there. I know you guys are probably meeting after this, but I will unhook.
Yeah, great program. Thank you so much.
Thank you.
Thank you, Doug, for that. If I hadn't told you, college basketball starts in 22 days.
Vanderbilt?
Go Panthers!
Woo!
Yeah.
Panthers play tonight. Anything else for the Rotary? Let's see. Robert, will you lead us in the 4-way test?
Is it the truth?
Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, independent